everybody, to another Sydney Neonatal Lectures webinar. Today we got Professor Martin Kluckow. He's, of course, one of the ground layers of getting a bedside ultrasound to help us better understand neonatal hemodynamics, where we have various topics from, hypotension, PPHN, sepsis, and of course the patent ductus arteriosus. And I think that's where it all started with Martin and Nick Evans, where they first started to explore what is actually the role of this. And I asked Martin to take us sort of to a journey of of these 30 years ago till now. So he's going to take us to this journey of the PDA past, present, and future. So Martin, over to you.
Thanks very much, Kurt, and thanks for that invitation and the idea to do this. I mean, it's a great idea to go back through 30 years of history of ductal research as seen by a particular individual or by our research groups here in Sydney. So it's been interesting just going back. I found a couple of studies and papers that I'd completely forgotten about. So that was a great opportunity. So here's where it all started at King George V Memorial Hospital for Mothers and Babies at Royal Prince Alfred Hospital in Sydney, where I was doing my neonatal training as a fellow in neonatology in 1994. And during that time, I came across this group of likely hemodynamic researchers, in particular Nick Evans, who became my PhD supervisor and collaborator and a great friend, David Osborne and Mary Paradises, who were part of the hemodynamic evaluation team at Royal Prince Alfred, and a fairly young looking myself, but it was 30 years ago. And as I moved a few years later, 1995, to Royal North Shore Hospital, I still maintained my links with RPA research, particularly with Nick Evans doing a PhD on the hemodynamic basis of cerebral injury in preterm infants. And that's another story we might talk about one day, is the whole blood flow, cardiac output in preterm infants. But today we're functioning on the journey from the ductal point of view. And of course, I met Kurt, who spent a year in the RPA nursery, and he became a strong collaborator, sharer of slides, and a couple of his slides are in this talk today, and a really good friend. So the history of the PDA, a bit further back than my history, is that it's a fetal shunt. It was clearly seen in anatomical specimens. In a preterm infant that persists, in a term infant it closed most often. And the story was, if it didn't close, then we should close it because that will return the physiology to normal. That was the assumption. And so that concept's been there a long time in the literature. Now, I quite like this timeline, which was just published just at the end of last year, the timeline of the general concepts that have shaped ductal thinking. It's starting with these anatomical descriptions back in the early 1500s, the illustrations of the DA, the ligation, the understanding that the DA constricts with breathing and with oxygen, the interest in prostaglandins for regulating the ductus arteriosus, and then the beginning of non-steroidal trials for PDA closure as part of that. As we move into the 80s, starting to characterise the ductus a little bit more in terms of susceptibility to drugs. The whole prophylaxis and the TIP trials was in the early 1900s, 1990s. And then PDA trials for different occluding devices. The genetics started to be more interest. And then we get the era of ultrasound and the classification of babies using ultrasound, the so-called TN echo, neonatal performed echocardiogram, scoring systems. And then the sort of backlash to conservative treatment, non-treatment of PDA, which occurred in the last decade, and then moving forward here into the 20s, some of the ideas that might be coming out which will help us manage the duct in the future, the FDA-approved closure device, advanced genetic studies. And I would add to that, and you'll see at the end, the physiological subtyping or personalised medicine, which is the next new advance in ductal physiology. So this is where we entered the timeline about 1995, and our contribution to that was this paper here, which was the first paper looking specifically at ductal diameter and its relationship to ductal patency in preterm infants undergoing mechanical ventilation. This was almost 30 years ago that this paper was published now in 1995. The ductal diameter, 1.5 millimetres cutoff, was derived from this cohort of patients, and the paper's been cited almost 230 times since its first publication. So it's a fairly simple idea to identify early echocardiographic markers, which allowed the prediction of subsequent symptomatic PDA. There's 116 babies in the cohort. They were all less than 1,500 grams. Interestingly, they were all mechanically ventilated. It'd be hard to put together a cohort like this in the current era where many of these babies would not ever be ventilated. And we looked at 4 potential markers: the LA aortic ratio, the pulse Doppler measurement of left ventricular output, minimum diameter of a colour Doppler signal within the course of the duct, and the direction of post-ductal aortic diastolic flow. About just over a third of babies developed a PDA which required treatment. That was just a clinical decision made by clinicians later after we'd done the measurements in the first 24 hours. And we found that we could, that a ductal diameter, that we're using an ROC curve, the ductal diameter was the most predictive. If it was greater than 1.5 millimetres. And it was 83% sensitive and 90% specific in terms of predicting the need for subsequent treatment. This is some of the illustrations from that original presentation, showing the concept of these were what our colour Doppler images looked like in those days. So you could see very pixelated and not as clear as what we get from our ultrasound sound machines currently. But we had the concept of that we could see there were small PDAs and large PDAs, a 1 millimetre PDA, a 2.3 millimetre PDA, demonstrating it was measured at the point of maximal constriction just before it came into the pulmonary artery. So that was the original requirements for a ductal diameter measurement. We looked at this data in different ways. One way was just to look at the actual ductal diameters in the 24-weekers, 25, 26-weekers, so each gestational age group. And you can see there was quite a range of diameters in each gestational age. And in this review paper, a few years later, we defined that a little bit more, the display of that a little bit more. Hang on a minute. By highlighting the babies in blue are babies who went on and needed treatment. The babies in red are babies who closed no treatment, again, per gestational age week. And you can see that if we made the cutoff at about 1.5 millimetres, the majority of babies requiring treatment would fall into this group greater than 1.5 millimetres. So this was the fairly simple definition that we came up with in the first few years as we were looking at predictors of babies who needed treatment for their PDA, and that's where the measure of 1.5 millimetres first came from. And you'll see as we go through this talk that has been used almost uniformly for pretty much every major ductal trial in the subsequent 25 to 30 years, until its use has been questioned just in the last year or two. We didn't just look at ductal diameter according to, in that paper, there was another string of investigation assessment where we took all of the babies who had had ductal diameter measurements, so it's over 400 babies, and they had an average gestational age of 26 weeks, and we looked at their first ductal measure and at the age at which they had that done. So you can see here, this is ductal diameter on this axis, and this is the postnatal age in ours, and there's generally an overall reduction in ductal diameter with postnatal age, and we're talking just 12 hours here. And in fact, that was quite a powerful influence. So the actual postnatal age changes were of more influence than gestational age correlates. And this regression equation was derived from this set of data, and it's been used in 2 subsequent big studies. One of them is the DETECT study, which is our study. But interestingly, it was also used in the TRIOCAPI trial, the French trial with Jean-Christophe Rosé, as a predictor of a large PDA. So basically, what we did with this data is we looked at the 50th percentile in each 3-hour group, and determined what the 50th percentile for the ductal diameter was. And so if babies were greater than that, then they were classified as a large PDA. And you can see that that number decreases as the postnatal age increases. And so that's something that has, apart from those two trials, hasn't really been taken up as a big effect on the ductal diameter of the postnatal age. So interestingly, you'll see that this paper was presented for the first time the PAS was in Hawaii, Honolulu. So I don't know if that means that's why we never got round to, we were just a bit laid back after that presentation. We never got round to actually publishing this as an independent trial, though as I say, it was used in 2 major trials subsequently. So duct diameter is simplistic. It's subject to operator error, place to measure, what the various settings on the ultrasound machine is, particularly the color gain, the variation in angle, variation in the diameter of one image. The use of 2D has become easier as we've had better definition. We often see a 2D image clearly now, and so we don't tend to use the color image, or we use both together, color image and a 2D image, whilst initially we were mainly using the color image because the 2D images were quite inferior. Diameter is an important factor, but there's other things, as we know, particularly flow volume, and the flow is dependent on a number of things, including the pressures at each end and if what's going on in the systemic and the pulmonary circulations, and other things like viscosity. Longitudinal diameters might improve by the same operator, may improve prediction, and we certainly are now doing that. So we'll look at, we might measure a duct in the first 24 hours and then wait till the second 24 hours to get an idea about whether it's getting smaller, getting larger, or not changing, and that has some influence on the decision to treat. And we combine it with other measures to assess shunt volume as well. And so an example of that would be another paper that we published looking at the relationship between ductal arterial flow patterns and ductal diameter to see how they relate. And the flow patterns that you see here, which you'd probably be familiar with, were from Dr. Su in Taiwan, and first published by him, showing these typical patterns of a pulmonary hypertension pattern, a growing pattern, a closing pattern, and a pulsatile pattern. And so, and you could see here, particularly the pulsatile pattern was particularly predictive of a subsequent need for a clinic or a diagnosis of a clinically significant ductus arteriosus, 100% specific and 93.5 sensitive, which seems almost unbelievable, very accurate. So we, in this paper, looked at the relationship between these two things, the ductal diameter and the flow pattern. And when compared to ductal diameter, there was quite a lot of variation, but there was a significant association. 98% of babies with a closing pattern had a duct less than 2 millimeters. Mean diameter was greatest in the pulmonary hypertension group and progressively narrowed across the growing and pulsatile groups. And it was smallest in the closing group. So this is what that data looked like. Ductal diameter on this axis and the different categories of flow patterns here. And you can see there is a relationship with the progression of these flow patterns. So some value in combining the two together, which is what we often do to make, again, a treatment-based decision, as we, particularly if there's a pulsatile pattern, then that is directed for treatment. It's more of a closing pattern, and here we saw that's associated with quite small diameter ducts. Often go on and close by themselves if they have this closing pattern. So over the next 10 years, ductal diameter was progressively used in more and more clinical trials as an entry point for randomization. But there were other things that were happening and other groups that were trying to improve the predictive effect of diameter. And you can see this is data from Afif Al-Kafash's study, a multi-center prospective study of 140 infants, small, 26 weekers, and the development of a PDA score with the numbers between 0 and 13. There were 5 elements as this PDA score, and taken at 48 hours. Gestational age, PDA diameter was still in the mix, but there were other things that we used to modify that. The Vmax of the PDA, the left ventricular A prime from tissue Doppler imaging, which is one of the things which has turned people off using the score system a little bit, that there's an extra level of expertise required to measure this. And then the left ventricular output. So most of these we're familiar with. This is the one that's a little bit more difficult. The score's been used to look at chronic lung disease at 36 weeks or death as a predictor, and a cutoff score of 5 discriminated between these two groups. So no chronic lung disease death in the babies less than 5. There's and here's chronic lung disease, CLD, and death in babies who are greater than 5. So there was a split point here which could be used clinically. And this is what that data looks like on a receiver operator curve. You can see the PDA score is here performing best, right out on the left-hand corner. The clinical characteristics were next. The gestational age was next. And then here's ductal diameter on day 2 by itself. And you can see it's the least predictive of all of the other parameters. And so I suppose this was the beginning of the questioning of whether ductal diameter alone is a useful measure. And this is 10 years after the original publication. But as you'll see, this group went on and has continued to challenge the use of diameter by itself as a parameter. We're looking at other things as well, and this is another interesting area of research that we came across, which was the relationship between ductal shunting, high pulmonary blood flow, and pulmonary hemorrhage. And so, again, using one of our cohorts of babies, we looked at that association, and we estimated the pulmonary blood flow from right ventricular output added to ductal flow, estimated ductal flow, and that was the pulmonary blood flow. And here is a box and whisker plot showing the babies who had no pulmonary hemorrhage versus the babies who had pulmonary hemorrhage. You can see that there is, as babies' pulmonary blood flows increase, their risk of pulmonary hemorrhage increases. And that was related to the ductal diameter. So ductal blood flow was part of that calculation of pulmonary blood flow. And you can see here that if we plot ductal diameter and gestational age, here's where we're looking at now pulmonary hemorrhage, not ducts failing to close, but pulmonary hemorrhage. So babies who had pulmonary hemorrhage were generally greater than the median level for the ducts for all of that gestational age. So bigger ducts, increased risk of pulmonary hemorrhage. And this is in a different format in a box and whisker plot, so that in one of the studies, 12 pulmonary hemorrhages, the majority of them had larger PDAs compared to babies who had no pulmonary hemorrhage. And these were measurements done in the first 12 hours. So this observation about pulmonary hemorrhage in relation to pulmonary blood flow and duct was something that we wanted to investigate a little bit further. We went back and had a look at the TIP trial, which is the big prophylaxis trial at indomethacin, so where babies were given non-steroidals in the first 6 to 12 hours. Interestingly, in that group, there wasn't any effect on indomethacin on pulmonary hemorrhage throughout the whole cohort, which was over 30 days was the outcome that they looked at. But in this paper, which reanalyzed the data and looked at just babies who had pulmonary hemorrhage in the first week of life, you can see that here, if babies were randomized to indomethacin versus placebo, there was a gradual change increase. So the cumulative risk for a pulmonary hemorrhage was less in the indomethacin group. So here was some corroboration that babies who got early treatment with indomethacin also had a reduction in pulmonary hemorrhage, but it was only in the first week of life, not the first month of life. So that was something that supported our hypothesis that there is a relationship between ductal shunting, pulmonary blood flow, and pulmonary hemorrhage. And that was further explored later on in the DETECT trial, where one of our outcomes was pulmonary hemorrhage. There are other things that we did around this time. So early ductal shunting and intraventricular hemorrhage was an important string of area of investigation. In ventilated preterm infants, the same cohort of babies we used for ductal diameter, but we were now interested in the relationship between larger PDAs and ventricular output, and there was and how that then related to intraventricular hemorrhage. So having compared babies who had with their PDA diameters, their ventricular outputs, and IVH rates, what we found was there was a lack of the two main predictors of IVH in this population were lack of antenatal steroids and larger PDA diameters. And so that was, again, the beginning of an area of interest for us, which is looking at blood flow and intraventricular hemorrhage and ductal blood flow and the associations between all of these three things. The big prophylactic indomethacin Cochrane review by Fowley in 2011 showed this effect on IVH, so a reduction in IVH. So one of the things we were interested in is whether this prophylactic indomethacin, it may have a direct effect on prevention of IVH, but also it may be an intermediary, the PDA may be an intermediary here, and that indomethacin is actually reducing the size of the PDA or closing the PDA. and that is why there's protection from IVH when babies are given indomethacin. It's one of the few positive outcomes of ductal treatment or provision of non-steroidals that we see in these big meta-analyses. And we were interested as to whether the duct was the linking interest here. A few other things, some of them which I wish I'd gone into a little bit more along the way. We published this paper on prostacyclin levels, so that was the beginning of an interest in the basic science of ductal physiology and working with some basic scientists to look at predictors for ductal patency. And then associated with this, I suppose, is an interest in pharmacokinetics and pharmacodynamics, which haven't really developed, but I think that's an area that we're really lacking in at the moment, is understanding the levels of the non-steroidals we give to babies, indomethacin, ibuprofen, paracetamol, and what are the right doses for babies to get clinical effects. And we may well be underdosing some of our babies, but we just haven't got the data to understand what the levels are in the current clinical age. So that's an area of a knowledge gap. And did other things, did a review ultrasound looking at a review paper looking at hemodynamic assessment of the PDA beyond ultrasound. So there are a lot of other potential factors for predicting a significant PDA outside of the cardiovascular system, but none of them really were particularly inspiring when I reviewed them. Also haven't really followed up on things like platelets and biochemical markers and the relationships to the PDA. But there may be some things here which might be we need to come back to and look at when we're trying to look for accurate prediction of babies who are getting into trouble from a PDA. So that was the beginning of the studies into PDA, ductal physiology, relationships to pulmonary hemorrhage, to ductal closure rates, and the relationship to interventricular hemorrhage. Then moved into an era of PDA trials, and this was sort of in the 20s from 2003 through to 2020. And there was 4 trials I was involved in with different groups of collaborators, but Nick Evans was involved in the first 3. First was an RCT of indomethacin versus placebo, the effects on ductal constriction and SVC flow, which was published by David Osborne in 2003, and then the DETECT trial of early targeting indomethacin, published 2014, PDA trial of later paracetamol, which was published in 2019, and then finally the more recent trial, which I published with Kurt, pilot and feasibility trial of early targeted non-steroidals. So it's looking at the feasibility of early targeting in the current age. So just a brief review of each of these studies. So the first study was a randomized double-blind trial of indomethacin versus placebo, 111 infants less than 30 weeks in the first 12 hours of life. Again, infants were eligible if they had a large PDA defined by ductal diameter greater than 1.6. 70 infants randomized to receive indomethacin or placebo. Now, this is an interesting study because it was one of the only study we've been involved in where we actually tried to look at a pharmacodynamic effect. So what we were interested in was, when we gave indomethacin, was there a constriction of the PDA which was measurable 1 hour after the treatment? And if there wasn't a significant constriction of the duct, then babies were able to be crossed over, so that all babies in the end, well, not all babies, but babies who didn't constrict their duct were able to be given the other treatment, which could have been the active drug indomethacin. So it was a pharmacodynamic study. And we found that at 1 hour, there was no difference in the DA constriction. It was 20% reduced in indomethacin and 15% reduced with the placebo group. So indomethacin at the dose we used, which was 0.2 loading dose, then 0.1, had minimal effect on ductal constriction and blood flow at 1 hour compared with placebo. And failure of ductal constriction was also an adverse predictor of low SVC flow and subsequent late severe PIVH. So an attempt to try and look at a pharmacodynamic outcome, but didn't have, in the doses we used, didn't seem to have much effect. The next trial was the DETECT trial, the ductal echocardiographic targeting and early closure trial. That was my favourite named trial, the DETECT trial, and the abbreviations fits beautifully. So this was babies born less than 29 weeks were screened for a large PDA, again based on the range of diameters and postnatal age. They received indomethacin or placebo before the first 12 hours. Main outcome was death or abnormal cranial ultrasound. Unfortunately, the trial had to be ceased early because enrolment, we only got about halfway through an enrolment and we had a lack of availability of indomethacin. We screened 164 babies, 92 were randomised, 92 in the large PDA were randomised. The ductal diameter was that data that we looked at earlier, where postnatal age and the 50th percentile cut points for each postnatal age. That was what defined the large PDA. And what we found ourselves, again, no difference in the main outcomes, but we were underpowered for that. Infants receiving early indomethacin had significantly less early pulmonary hemorrhage, and there was really quite a difference, 2% versus 21%. There was a trend towards less PIVH, but small numbers. And babies also were less likely to babies who received indomethacin were half as likely to receive later open label treatment, 20% versus 40%. Interestingly, we did track the babies who were identified as having a small PDA in the lower 50th percentile, and they were at a lower risk of pulmonary hemorrhage and had an 80% spontaneous PDA closure rate. So there was some utility to categorising babies above or below the 50th percentile for each postnatal age 3-hour group. And this is just a summary of the data, the 44 babies with indomethacin, 48 with the placebo. Here's the pulmonary hemorrhage in the first 72 hours. You can see 10 of the placebo group and only 1 of the indomethacin group, so a marked difference. And this open label treatment reduction to 20% in babies who had indomethacin or 40% placebo. And this is one of the issues we have for current trials is the rates of open label treatment. So the DETECT trial was a targeted treatment of a large PDA in the first 12 hours, no difference in IVH, abnormal cranial ultrasound, significant reduction in early pulmonary hemorrhage, less open label treatment, and interestingly also no increased risk of SIP, NEC or GI tract bleeding in the indomethacin treated group. Third trial was one on using paracetamol for later PDA. It was a multi-centre, 3 centres, Canberra, ourselves and Royal Prince Alfred, randomised in a pilot trial. Infants were born less than 33 weeks who had a postnatal age greater than 14 days with a hemodynamically significant duct, were treated with a 5-day course of oral paracetamol or placebo. The primary outcome was ductal closure. Secondary outcomes were reduction in ductal diameter and safety. And we enrolled 55 infants. 80% had received previous non-steroidals. Mean postnatal age was 25 days. 4 of the 27 ducts treated with paracetamol closed, and none of the 28 treated with placebo did. And there was an additional 13 out of 27 who constricted versus 7 out of 28 who were in the placebo who constricted. So if you combined the closure and constriction together, it was a significant effect. So there was the paracetamol did close the duct at a later time point in the doses we used. And finally, the most recent trial, a randomised placebo-controlled study, pilot of early targeted non-steroidals. And this was the idea behind this was to be a pilot trial to see if we could enrol reasonable percentages of parents in an interventional trial, and also if we could limit the open label treatment rates in that trial for future large randomised trials. And so we had preterm infants less than 39 weeks with a PDA diameter greater than 1.5 millimetres and less than 72 hours after birth were randomised. No open label NSAIDs were allowed in either arm, but babies did get supportive management, including diuretics, fluids restriction and CPAP. And again, we found we could enrol just over 50% of babies that were approached. So there was some clinician equipoise. The rate of open label treatment, only 2 out of 72 babies received open label treatment. And with the secondary outcomes, PDA closure rate was higher in the group that received non-steroidals versus placebo. And there's no other differences in clinical outcomes. So again, 4 trials, all of which use ductal diameter for enrolling as a large PDA. At the same time, there's 4 major trials which I haven't got time to review. The PDA Tolerate trial, but just looking at what they used, and you can see again they use large PDA greater than or equal to 1.5 millimetre and 1 other hemodynamically significant parameter. The Trio Capi trial from Rose in 2021, large PDA, again they're the ones that use that algorithmic approach with the postnatal age versus ductal diameter. The Benedictus trial from Willem de Bood, large PDA greater than 1.5 millimeters with left to right duct, left to right shunt. And finally, the more recently published Baby Oscar trial by Samir Gupta, large PDA diameter greater than or equal to 1.5 millimeters with pulsatile flow present. So again, all these major trials all use ductal diameter. So I suppose that really brings up now, here we are 28 years later, having described that original ductal diameter measurement, is it really something that is useful to us in trials? And I think I've accepted, and certainly this group here made it very clear in their, not only this paper, but also in the talks they've been giving in the last year or two, that future RCTs for PDA treatment should strongly consider abandoning the use of PDA diameter in isolation as a criteria for recruitment into clinical trials. And I must say I do agree with that, even though I was integrally involved in the original production of that concept. So why aren't we seeing benefit in trials apart from patient selection, as we've talked about, and whether ductal diameter is appropriate? We've also got this problem that when we design a PDA trial, there's a couple of things which happen which are different to other trials. If we've got a placebo arm on the left-hand side, active arm on the right-hand side, each of them is subject to spontaneous closure. So even in the placebo arm, we may get closures, not because of our treatment, but because of spontaneous closures. We've got the open label treatment as well. So each of the trials will have quite often there's a percentage of open label treatment. You saw in our initial DETECT trial that was up to 40%. And there's also, obviously in the active arm, there is active treatment closure. And then we've got the final thing here, which is that in the active arm, we may give treatment appropriately, but the duct may not close. So we end up with a baby who's still got an open duct, even though they're in the active arm. So we have, even though we've got two arms, placebo and active, the problem is that we have little difference between the groups because of the combination of spontaneous closure and open label treatment. So we need to maybe be more careful in discriminating our groups. The other trouble is we assume that the placebo arm is a baby who's got an open PDA and that the active arm is a baby who's got a closed PDA, but clearly that's not always going to be the case. So that makes our treatment decision difficult, and we're faced with a treatment benefit risk equation each time we make a decision about the ductus arteriosus. We've got the risks of non-steroidals, of surgery complications, lack of benefit, the spontaneous closure rate, which would mean we're treating when we don't really need to. And then we've got prevention of respiratory or cardiac decompensation as one of our main aims of giving treatment, avoiding mortality. And we've seen there's associations between IVH, pulmonary hemorrhage, and also low blood flow, low blood pressure. So I think there are overall group benefits when we look at groups of babies, but how do we individually guarantee that our baby gets appropriate treatment and responds to that? The other thing that makes it a bit harder is we've got less intensive babies, so we're less inclined to give medications that might have side effects in babies who are quite stable on CPAP, in air, no invasive lines, no inotropes, early feeding. They're all disincentives to treat babies who might have a single PDA with a ductal diameter greater than 1.5, for example. And then we've got things that are happening. We've got more benign drugs potentially like paracetamol. We've got better in selection and timing because we are learning a little about when the best timing is for treatment or ligation. And we've got less invasive measures coming on board, particularly the catheter-based closure and the new smaller devices which can be used in smaller babies at earlier time points. And we've got other things that are happening on the benefits side and things that need to happen, including pharmacokinetic studies to try and improve the efficacy of our drugs when we do get benefit. So what can we use to help us select patients? And this is the narrative that's also been going on with the ductal studies and ductal involvement, is how we actually get access to tools to be able to assess ductus arteriosus as clinicians ourselves, rather than asking cardiologists to come and review babies. And so we have the concept of clinician-performed ultrasound, which you'd all be quite familiar with a focused study at the bedside in real time, can be serial, mainly function or assessment of function, understanding the individual physiology, which in the duct is very important, refining the decisions, targeting the treatment, and seeing if we get response. So bedside ultrasound is really crucial to being able to look individually at patients' ductal status. And so this narrative's gone along at the same time. This is back in 2007, coined the term functional echocardiography to describe what we as neonatologists were doing to use ultrasound to assess physiology. And it's separate to the structural echocardiogram done by a paediatric cardiologist, and was increasingly being utilised, particularly for PDA management, and I think it's still the case today. We published a paper actually in paediatric cardiology, which gave us access to paediatric cardiologists and really got them to understand that what we were doing as neonatologists was different to what they were doing as cardiologists. And again, enhancing the understanding of physiology. And then Kurt and I published this paper in 2010, which is, believe it, it's still 14 years ago. It seems like only yesterday. Looking at functional echocardiography and from physiology to treatment, and looking at the groups of babies in the NICU who can benefit from ultrasound and targeting of treatment. And this is a more recent review in 2018, looking at the role of neonatologists performed echo in the assessment and management of PDA, and how important ultrasound has been in assessing the ductus arteriosus. This is a cartoon from that paper, just starting to sort of give some idea of the amount of detail that we can get from ultrasound that might help us in our decision, particularly when we're assessing the degree of shunt. In other words, the difference between QP, the pulmonary flow, and QS, the systemic flow. We've got the clinical associations for each of these: pulmonary hyperperfusion, systemic hypoperfusion, and the actual PDA itself. But we've also got the echocardiographic parameters here. So there are a number of parameters for assessing pulmonary hyperperfusion, a number for looking at systemic hypoperfusion, and then finally the PDA assessment itself, where ductal diameter sits amongst all these other measurements now. So this understanding where the baby is in this QP-QS distribution is likely to be an important part of the patient selection and responsiveness in the future. And so we have what I call the 3-vessel Doppler screen, but to quickly get some information just from a single ductal view here, we can look at the ductus arteriosus, and we can measure the diameter of the PDA. We can look at the flow through the ductus arteriosus and categorize it according to the SU classifications. We can look at the LPA as one of the measures of pulmonary hyperperfusion, and we can look at the descending aorta as one of the measures of systemic hypoperfusion. So we can get some of the key parameters here quickly from one single view. So, and there are a number of people, including Kurt, have published some of the norms of these, the direct assessment of the PDA, the excessive pulmonary blood flow measurements, including things like LA aortic ratio and left ventricular output, and the reduced systemic blood flow, including things like diastolic flow pattern in the descending aorta. So this sort of more focused assessment of the physiology is becoming more routine, and always routine in our nursery. Things have gone the other way a little bit as well. So this concept of therapeutic nihilism, I'll apply for the benefit of the sick all measures which are required, avoiding those twin traps of over-treatment and therapeutic nihilism. It's from the modern Hippocratic Oath. Therapeutic nihilism is a contention that it's impossible to cure people through treatment. It's connected to the concept that many cures, and in our setting that would be non-steroidals, do more harm than good. Therefore, one should encourage the body to heal itself or the PDA to spontaneously close. So many people have moved from the treat all to a broad selection to a targeted selection, which is where we're at. And then the concept of not treating any babies at all. And will they come back, or will things move back towards personalised medicine where individual babies are given treatment in a personalised way? So Kurt published a review of this with Rahul and myself, looking at the role of conservative treatment. Is it safe? How many babies are being exposed to it? And there's a series of tables in here which are really useful, documenting those concepts. Part of the problem is poor efficacy, as we know, of the currently available treatments. So therapeutic nihilism in PDA management will limit our progress if we just close our eyes and don't treat any babies at all. This is data which I'm sure you're all familiar, looking at what happens if you don't actively treat babies with a PDA, and this group managed to treat only very few PDAs early on. You can see this is PDA prevalence, ductal arteriosus closure date, and you can see that the bigger babies close their PDAs pretty quickly. But if we take ourselves out to this group of babies less than 26 weeks, the median closure was at 71 days. So that's 10 weeks of exposure to a shunt. So the question is that healthy for a preterm baby as well? And also important to remember that 43 of the 280 babies in this study had an open ducted discharge, which creates a whole lot of issues as well. So to try and prevent that therapeutic nihilism, we need to be able to select candidates who have better responses, better longer-term benefits, and decreased side effects and harm. So there's a number of ways we might achieve that. And a lot of that is related to ultrasound measurement, as we've discussed, and being able to measure these fairly simple but extended evidence of hemodynamically significant PDA. So just looking now a little bit to the future, as we've seen what's happened in the past and where we're at now. As we get to the future here, this is the next thing that I think is going to become more important, and already the hemodynamic sort of hubs, Alkafesh, McNamara, and our group in Sydney are moving more towards trying to understand individual patient physiology, and it may be more than physiology. It might be genetics, it might be responses to drugs as well. So the latest publication I've been involved in is the Neonatal Hemodynamics 4th edition, which is just about to be released. And in there is a chapter by some local hemodynamic researchers, Steph Boyd and Libby Fisher and myself, looking at pathophysiology-based management of a hemodynamically significant duct. And this concept of PDA phenotypes, so 6 different phenotypes were discussed in this chapter. Haven't got time to go through them all, but you can get the book and have a look yourself. But each of them is defined as a definition from a hemodynamic point of view. There's typical clinical scenario, the clinical features, the cardiac ultrasound findings, and then the management. And then the management is different for each of the phenotypes. So this concept of understanding individual patient physiology is likely to become more important. And it goes like this. This is a good illustration of this from Willem de Bood, going from this empirical one-size-fits-all where we don't really take any notice of the underlying physiology, which is where we've been. And that's an example of just the simplicity of a single ductal diameter without looking at anything else. Moving through to this more individualized hemodynamic management of individual physiologies. And then finally, the concept of that each patient is managed completely individually. So that's the specific clinical characteristics of each patient are taken into account. So this is the true personalized medicine. So the ability to look at both clinical characteristics, echocardiographic, possibly biomarkers, going back to some of those other non-ultrasound markers, the timing of treatment, the dosing and individual pharmacokinetics. We need more work on that to be able to understand that more. Use of predictive algorithms is going to become more important, and possibly the genetics of the PDA and how well they respond to non-steroidals, for example. One of Kurt's slides, but these similar shared ideas that we've had looking at this concept of what's happened in the past yesterday, where we were looking at symptom-based data and intuitive medicine, where we're at today, which is cohort-based babies and evidence-based medicine, but we know that it's not really helping us. We're getting lots of negative trials and negative meta-analyses. And the future, where we'll be more algorithm-based, and the true precision medicine will hopefully become a thing that we do every day. So that means that we need to put resources up front in our clinical trials so that we can actually identify individual physiology before a patient gets randomized rather than post hoc. So focus on developing guidelines to identify infants at high risk of adverse effect from the PDA. This will require a more physiological approach using CPU and clinical effects particularly. And then we need more study and understanding of pharmacokinetics and pharmacodynamics of our prostaglandin inhibitors. So what should we use to guide us? Well, at the moment, we've got the big evidence-based medicine group, which is still very influential. And I think there is still some usefulness in being involved in evidence-based medicine, clearly. But we need more. We need our individualized medicine as well, so in selected patient subgroups. So the role of dividing babies up physiologically, particularly using ultrasound, as an important part of the whole of ductal management, I think will continue to be and become more important as the years go on. So I'll finish up there, and I'm happy to take some questions or debate we'll talk about what we do in our unit. There's plenty of things I didn't show in this talk, but if there's any specific things you'd like to see or talk about, by all means ask, because we've got 15 minutes.
Thanks, Martin. This was indeed a wonderful overview of the past, the present, and the future. You showed the initial sort of studies looking at the PDA, just trying to get to know the PDA, basically. And I have a question about that in a moment. And you went to the present, or the where there was trials, but they haven't really pushed this forward that much because they put too much of the same into the category, and the future where you want to select these patients. You've shown a bit of the progress in ultrasound and ultrasound techniques, but also clinical ideas and genetics and pharmacokinetics still to come, I guess. You know, back to the drawing board is certainly one of the things which comes to mind. And so this is indeed, I think, where we are. I was really impressed, and I really like your chapter in your book about these different types of PDAs in different clinical situations, because it takes into account the timeline. And in that timeline, there are two types which are early. Maybe you can tell us a bit, how difficult is it to do ultrasound studies during the transition?
As a person who's done a lot of ultrasounds in that time, so yeah, I think that first of all, we need good ultrasound machines, and so they need to be high quality, for particularly doing ultrasound on small babies. We don't want to be using low quality ultrasound when we need high penetration and the definition of structures. And I think there's also a skill in being able to know when there is a good time to do a scan for a baby and when it's not. So time frame of care in the industry is very and a relationship with an understanding from the nursing staff about the benefits that we might get from ultrasound versus the perceived upset that might occur to the baby having that ultrasound done. So that needs to have been sorted out to make life a little bit easier. And then, yeah, we in our nursery we don't teach and train on very small babies. We in transition, that's done by the senior clinicians. We start on less fragile babies. So I think there's some things you can do to make scanning easier, but it is still potentially a disruptive thing to do in a baby, and it may actually change the physiology that you're looking at as well. So I think you need to be aware of some of these issues as well as you do ultrasounds upfront before treatment, rather than doing a quick ultrasound saying they're in this group and then saying, okay, we'll give them treatment.
So yeah, and I guess the question here is, what will be in the first 24 hours, if you had to pick a time, what's the optimal time, you think?
Well, I think it depends a little bit on what you're trying to achieve with your treatment and what you believe in. So, for example, in our nursery, we still believe that an early dose of indomethacin, a la the TIP trial, is a useful thing to do, particularly in certain subgroups of babies, male babies, ex utero, not steroid covered, and possibly also a large unrestricted PDA with reverse flow in the descending aorta when you actually get round to doing the ultrasound. So there are some things to guide on that. Yeah.
But like before 12 hours, or?
Yeah. So we do. So the benefits for that, if you're trying to avoid IVH, for example, then you need to give it earlier than the period when IVH occurs. So yeah, so we usually give, if we're giving prophylactic indomethacin, it's usually in the first 12 hours. So that's a slightly confused area, because sometimes we're giving it for neuroprotection, sometimes we're giving it for the duct, but both of those things go together, I think, because I think that the duct is often something that then destabilizes these babies in the first 12 hours as well. Yeah, so we try and do our first ultrasound on some very small babies in the first 12 hours. And beyond that, the next mark would be 72 hours if we're doing early treatment. And as you've alluded to, not all babies are going to be amenable to early treatment. So
there's another question about timing, and that timing is later on. When would you go for surgical or cath closure?
It's an unusual thing in our nursery these days, is to go for a surgical ligation. We've sent a couple of babies for cath, and I think because the threshold points may be different there. But we we don't usually send a baby for consideration for ligation unless they're going to cardiac failure. So they've got a dilating heart, increasing left ventricular output, and evidence of increasing need for oxygen and or ventilation, respiratory support. So yeah, we let them go. Now, that's not necessarily a good thing to do. I mean, I suppose it's just, again, it's this risk-benefit equation, is when the benefits start to outlay the risks. And because we're in a unit where we have to transfer a baby to another hospital, there's a lot of other factors that need to be considered. It's not just simply about the ductal closure. It's about all the things that might happen on the way there in terms of, you know, fluid management, steroids, those sorts of things. So we're a little bit more cautious about which babies we send over in that setting. And we usually probably wait a week or two more than we should do, I would say, just to be sure that they're in that category of needing treatment.
Yeah, it certainly makes a difference if you have the surgeons on site or the intervention cardiologist on site versus not, I guess. Two questions are related to supportive care. You know, what is supportive care? What do you do? Do you do anything different with the level of PEEP, fluid restriction, and diuretics?
So that was, of course, the paper that we did together, and I think that was where we started as well. Is, you know, what are people doing? Is there any evidence for it? And what you found is there was virtually no evidence for any of those practices, and that the decision to sort of move across to supportive care has been taken without. It's not really an evidence-based thing. It's just it's people saying, well, we're just returning babies to normal physiology and not intervening. But I mean, clearly, if you see that group of the babies less than 26 weeks in the Sembrov study, they've got 10 weeks of exposure to a left to right shunt. So it gets to be sometimes a bit like a, you know, a congenital heart disease type problem, VSD, big ASD. You know, you've got a baby who's destabilizing because of that. What do you do? And yeah, I mean, if we are waiting for a baby to try and decide if they need ligation, we do put up their CPAP. We do manage their fluids, which often restrict fluids. Occasionally we give diuretics if there's evidence of worsening oxygenation and wet lungs. So, and we use them all just like titrated to what the baby requires, I suppose. But yeah, it's an area I think that probably needs a bit more study as to whether there's any harm in exposing a baby to that longer shunt, and using the conservative measures to try and control that shunt. Yeah.
And there's indeed surprisingly little evidence on the use of diuretics in this particular population of volume overload and maybe, you know, raised left atrial pressure. One of my colleagues, Neil Confat, is doing a study about this, and hopefully we can give you some information, you know, which patients whether they have a high left atrial pressure or not with the PDA, and how they respond differently maybe to the diuretics. And so, yeah, we don't have much information there as well. There's much more to come. Let me see what other questions or comments. It makes us feel like we do something, which is, I would probably agree. Yeah. All right.
Well, that was, of course, the premise with our study was the feasibility study was that it's not treatment versus no treatment. It's treatment with supportive care versus supportive care alone. And I think that's a very important concept to get across to clinicians and parents, that if we aren't giving any treatment, we are still giving supportive care. So there's an important difference there.
I have another question. So look, you've also been one of the front runners of, you know, teaching us neonatologists to do ultrasounds at the bedside. How do you think that has progressed in the field also of PDA?
Yeah, I think, I mean, the relationship between, sorry, Kurt, I was reading the chats. Just give me that question again.
So you have also been teaching us how to do these bedside ultrasounds. We stuck to a certain set of measurements, but more and more people are using it. How do you feel that it has progressed? I think it's going excellent, and more
sure.
using it appropriately.
Yeah, well, I think I mean, from the Australian New Zealand point of view, we've had an organised training program which has been there for more than 10 years now. And I think that's been very important in, you know, we luckily had a structure being the ASAM, Australian Society for Ultrasound and Medicine group, who had a model that we could fit into. So I think we've been lucky. We've actually been able to, as a country, quite well train our neonatologists to be able to do ultrasound, such that most units have got at least one, if not 2 or 3 people who can scan. And I think so I think it's gone really well from our point of view, and we're certainly held up as the, one of the countries which has done really well from the point of view of introduction of bedside ultrasound to the neonatal unit. We've also got good collaboration with our paediatric cardiologists, and some of those original papers that we published have helped smooth the way with our latest group of cardiologists and newer cardiologists understand what us neonatologists are doing. So yeah, I think that there's a lot of clinical management that occurs with ultrasound guidance now in our neonatal units, and we see that a lot when we sort of interact with other units. Often they've had ultrasounds done by the clinician. So I think it's gone really well, and hopefully we'll be manage to make this an important part of neonatal learning and training. And we haven't done that yet, but I think as we get to the point where we have trainers and people capable of training in every neonatal unit, we'll be able to then start to say that's a requirement for being a neonatologist. And I think a lot of people are interested in that happening. So.
Yeah, I support that. In any intensive care setting, including ED, it's becoming standard of care, and we need to follow. I like this question. There's a question about, the upper limit of gestation before you consider closing a PDA, because is a PDA, or, is there an upper limit?
Yeah, I mean, we know that spontaneous closure rates are very high for babies above 28 weeks. Even possibly above 26 weeks. So we're mainly interested now in the smaller babies, and those are babies unfortunately probably don't have as good efficacy with medical treatment, and more unstable for surgical treatment. But we would rarely give treatment for a baby above 26 weeks, and certainly not above 28 weeks. You get the occasional baby who's 31 or 32 weeks who goes into cardiac failure with a PDA. They've probably got a true congenital PDA, which is not sort of shown any sign of constriction. We rarely. So our upper limit would certainly be 28 weeks. It may even be 26 weeks now. Depends a little bit if the baby's on a ventilator and has got significant hemodynamic significance of the PDA, then we might still give treatment to that size baby as well. But above 28 weeks, no.
Yeah, from a trial perspective and trying to prevent the volume and the systemic perfusion, I guess we have to focus on the young ones. But indeed, every now and then, a bigger baby who just has a congenital abnormality, which is called the PDA, we have about one a year, I think we see of those. John Smythe, we talked about efficacy and what is the best efficacy. Combined drug treatment. Throw everything at them.
Good question, John. So, I at a couple of times over the last few years, I've suggested that combined drug therapy with paracetamol and ibuprofen, for example, might be a good idea. And there's actually a drug already on the market you can buy across the counter in chemists, which is called Neuromol, which has got ibuprofen and acetamol combined together. So it can't be too dangerous to give those two drugs together, or you're not going to suddenly switch off the whole of their prostaglandin production and cause some complication. That's what I was worried about combined treatment. When my daughter showed me a packet of Neuromol which had combined ibuprofen and paracetamol, I said it's probably fine. So, John, there is a trial which is going on at the moment called the ACE-DUCT trial, which has started enrolling in Canada, and Kurt and I have been having discussions with the principal researcher in that trial about bringing that trial to Australia. So we're starting to go through the process of putting it through ethics, etc. So we'll be polling people who are interested in being involved in that trial in the next 6 months or so, I think, once we've got some of the paperwork done. So the ACE-DUCT trial, and it's ibuprofen alone versus ibuprofen with paracetamol added in for treatment in the first 72 hours, though they do allow enrolments out to 2 weeks in specific circumstances. So I think it's a really good idea, and it gets back to the whole idea about trying to improve efficacy. But it also, it would be nice to have a little bit more actual information about what the dosing should be in the standard ibuprofen treatment and standard paracetamol treatment. So we still might get into trouble because we're not using the right doses, even in a combined trial, I think. So.
We got time for one last question, which is about, is it ethical to do more of these kind of trials? or should we now only allow sort of structural algorithms before we do the next trial?
Yes, so I think a good question is really what I was starting to say, that we've done a series of trials, the trials we were involved in, those 4 big trials now that I presented. I think they were ethical at the time. I think it's a bit tough to say they weren't ethical, because they all started, their preparation for the trial, 8 to 10 years ago now, which was sort of in the era when we were really just understanding the need for subtyping and the differences in babies. So I think they're reasonable trials to have done. But you're right, in the future, I think we need a more specific algorithm. And this concept of phenotyping and developing algorithms for management, we've already doing that even more specifically than the PDA ones when we're talking about blood pressure and blood flow and management of sepsis. And there's some really good algorithms out there now which are using ultrasound information to direct and target treatment, so that there'll be completely different treatments for different lines of babies. And I think that's where we're trying to head with the PDA as well, but we might need a bit more information, both from ultrasound and possibly from other things as well, to allow that subtyping to occur and actually see differences between groups which require different treatments. So.
All right, it's 2:01. Martin, thanks again for this wonderful overview of, well, and all the work you have delivered for us to read and build on to get to this sort of understanding where we are now. Unfortunately, we don't have a solution for the PDA yet. That will still take a long time, but we gave it a good go. I think that's really important. And we still have a lot of work to do. Everybody of the attendees, thanks for attending. Have good holidays. We'll be back next week again. I will send something out to the usual channels about what the program is for April. Thank you, all of you, and goodbye.